Hi and welcome to another video. Today I'll go over sickle cell disease. As a brief overview, I'll give you the key background information you should be aware of. I'll go over the pathophysiology and the clinical presentation of sickle cell disease, and then I'll go through some of the key investigations and management options before providing a quick summary of everything that I've covered. So, for some key background information, you should know that sickle cell disease is a genetic blood disorder which causes abnormal hemoglobin to form in the red blood cells, which can cause a lot of complications. It is an autosomal recessive condition, and it is a mutation of the beta chain of the hemoglobin, and usually the mutations are on chromosome 11. There's a carrier risk of 1 in 89 worldwide, but it's higher in the BAME population, roughly 1 in 10, and there's an incidence of 1 in 2,249. It is associated with lifelong complications and unfortunately with reduced life expectancy. However, we have screening for it these days, and in the UK, people are screened for it right after birth in the blood spot test. Now for a brief overview of the pathophysiology. With the genetic mutation, the GAG triplet code is replaced with GTG. So there is a substitution for a single nucleic acid. This means that the glutamic acid that would be coded for is substituted with valine, and this produces the HBS or sickle cell allele. The HBS becomes more prone to sickling due to this substitution. And during hypoxia, those erythrocytes quickly deform and bind to each other and are therefore prone to sickling as a result and turn rigid and crescent-shaped. This can cause vasoocclusion, and that in itself causes ischemia and inflammation due to those HBS tetramers binding to each other and polymerizing, especially in smaller blood vessels. In terms of the clinical presentation, in the UK, it is typically picked up during screening, and there's rarely ever a first presentation on admission. However, you should consider it possible diagnosis in older patients if they have recently emigrated from at-risk areas. Some of the things to be aware of for a sickle cell crisis include extreme and acute pain, fever, tachycardia, jaundice, dactylitis or inflammation of the digits, and shortness of breath, wheezing, cough, and hemoptysis if rather than just a pain crisis, it's an acute chest crisis, which is something to be aware of. In terms of investigations, many different ones can be done. First one being electrophoresis, which will detect the absence of HbA or the typical healthy hemoglobin. And there will also be high levels of HbF, which is the fetal hemoglobin, as the body will try and upregulate its production in order to try and minimize the amount of unhealthy HbS circulating in the body. You can also perform a blood film, which will detect the presence of nucleated red blood cells and sickle-shaped red blood cells, and you may also find Howell Jolly bodies. Those are indicative of splenic dysfunction, and they're associated with other conditions such as congenital asplenia and pernicious anemia, but they can also be found in patients with sickle cell disease. Another investigation you can perform is an X-ray of long bones, and it can confirm the presence of bone infarction. However, in of itself, it is not a diagnostic measure, but rather used long-term to determine whether any damage has been done over the course of a couple years, for example. Some places, instead of electrophoresis, perform something called a high-performance liquid chromatography, and in there you will see a peak in the S window on the graph, signifying presence of hemoglobin S, or sickle cell hemoglobin. This is different to people without the condition who will only have peaks on the A and A2. With regards to management, I would like to divide it into firstly acute management, so you would provide analgesia, oxygen, antibiotics, and IV fluids. It is important to know that these patients are in extreme amount of pain, and therefore appropriate opiate analgesia early on is crucial to minimize their suffering when they present with acute crises. For prophylactic management, you can give hydroxycarbamine, also called hydroxyurea, as it increases the amount of fetal hemoglobin being produced, but you can also do regular exchange transfusions in order to lower the amount of sickle hemoglobin present. Penicillin is one of the most commonly used antibiotics as a prophylactic measure in patients with sickle cell disease. However, pneumococcal vaccinations should also be completed regularly. And lastly, in severe cases, patients can be considered for transplant. For a brief overview of the complications, a parvovirus B19 infection can cause an aplastic crisis, which is why it's so dangerous in patients with sickle cell. And there are various vasculopathy issues that can come secondary to the vaso-occlusive crises, which includes chronic kidney disease, leg ulcers, pulmonary hypertension, and priapism. Lastly, patients with sickle cell are more prone to osteomyelitis caused by salmonella. So, in summary, sickle cell disease is an autosomal recessive condition that affects the beta chain on chromosome 11, where glutamic acid is substituted for valine, and this results in sickle cells having an abnormal shape, resulting in vaso-occlusive crises. Testing for it can be done in utero or immediately after childbirth, and treatment is lifelong, and life expectancy is shortened in those with sickle cell disease. This was a very brief overview of sickle cell disease. If you have any questions, leave them down in the comments. I hope this was very useful. I hope you consider liking and subscribing. Thank you so much for watching.